everyone, and welcome to today's Adult AML Chapter event brought to you by the HealthTree Community for AML program. My name is Katie Braswell, and I'm the HealthTree for AML Community Director. I'm very grateful to have each of you here for our meeting today and for your support in building this Adult AML community. I'd like to let you know that today's session will be recorded, and the recording, along with the slides and any resources we discuss today, will be sent via email to all registrants within 48 hours after the event has concluded. I'll start with a brief Zoom meeting tutorial for those of you who are new to using the platform. We would love for you all to turn on and keep your cameras on if you feel comfortable. Doing so helps to create a stronger sense of community. You can see on the slide how to turn on your camera. At the bottom of your screen, you should see the microphone and camera buttons. You can click the video icon that says Start Video in order to turn your camera on. With that being said, if you're not comfortable being recorded, you are not required to keep your camera on. Your microphone should be currently off and will be kept off by our team throughout the presentation. During the group discussion, you are welcome to unmute yourself once you're called upon. If you have any questions or comments for us or for our speaker throughout her presentation, please click the chat icon and type them in the chat box. If you're using a mobile device or a tablet, click the three-dot icon that says More and then Chat in order to access the chat box. And lastly, if you would prefer to verbally ask a question or make a comment directly to our speaker during the discussion time at the end, we encourage you to do so. If you're using a laptop or desktop, click Reactions near the bottom of your screen and then click Raise Hand. If you're using a mobile device or tablet, you can click the three horizontal dots that say More and then click the Raise Hand button. And now let's get started with today's event. First, I'd like to thank our sponsors, without whom this event would not be possible. Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. The topic of our event today is titled Know Your AML Therapy, Venetoclax. Here's the agenda for today. I will introduce our speaker, Dr. Mims, and she will spend the next 40 minutes or so giving us her presentation. After the presentation, we will open it up for your questions and comments and end the event with a few announcements. So let me take a second to introduce our speaker, Dr. Alice Mims. Dr. Mims is Associate Professor and Acute Leukemia Research Section Head in the Division of Hematology at Ohio State University. She is also Senior Medical Director for the Beat AML umbrella study investigating novel treatment in elderly AML patients through the Leukemia and Lymphoma Society. Dr. Mims's research interests include studying the effectiveness of new therapeutics on patients with AML and other myeloid neoplasms, and her work has been published in many well-respected journals, including Molecular Pharmacology, Leukemia, and Blood. We are so honored to have you here with us today, Dr. Mims, and we're really excited for you to share your knowledge with us today about Venetoclax. And so with that, I'll let you go ahead and get started.
Thank you so much. I'm going to share my screen. So hopefully, let's see, any issues with seeing that from your end?
No,
okay,
it looks
perfect. Perfect. So I wanted to say thank you so much to HealthTree and the organization for the opportunity to be here with you all today. I always love these opportunities to really get to directly interact with patients and family members, as I feel like I really learned so much myself from the questions and discussions, that occur at the end. So what I've been asked to speak about today is the topic of discussion around Venetoclax, and it really has changed the game for patients from where we were. However, you can see with the title, it's a step in a better direction, but we really want to continue to improve upon even the steps we've made with Venetoclax and continue to do a better job and aim for a cure for our patients. So some of the topics of discussion that we'll cover today will be how the landscape of treatment for patients with AML has changed, talk about the mechanisms of action for Venetoclax in combination with hypomethylating agents, and sometimes I'll refer to those as HMAs. We'll talk about patient outcomes with this combination therapy in the newly diagnosed setting. I also want to talk about management of patients who are on therapy and some of the complications and things that can come about, so you are aware of kind of expectations on treatment. Also to talk about some current topics of controversy with venetoclax and HMA therapy, and that's mainly some specific molecular mutations that the question is if venetoclax and HMA therapy are really the best choice. And then we'll end by talking about venetoclax in combination with a different chemotherapy, low-dose cytarabine in the upfront setting, and then a little bit about this combination therapy in the relapse refractory setting, and then talk about where hopefully the field is moving forward, again, to improve upon where we currently are. So as you can see right here, this is really the history of FDA approval of therapy for AML patients. And so, things started in the 1970s with 7+3 induction. Then the first bone marrow transplant came along later in the 1970s. And then we went 20 years without any advancement until the CD33 antibody gemtuzumab came along. Then idarubicin, which is an anthracycline that you can use instead of daunorubicin. And then gemtuzumab was withdrawn due to safety concerns, but with some adjustments came back into the market in 2017. And 2017 is really when all this big explosion occurred with drugs being approved for AML patients. So we also have CPX-351, which is a liposomal version of cytarabine and daunorubicin. We have our IDH inhibitors with enasidenib for IDH2 mutations, ivosidenib for IDH1 mutations. We also have FLT3 inhibitors with midostaurin, given in combination with 7+3, and then gilteritinib, which is a second generation FLT3 inhibitor that's approved in the relapse refractory setting. And then as you can see, venetoclax came around 2018 with its approval. And then glasdegib, which is a hedgehog inhibitor, also was approved in combination with low-dose cytarabine. And so things keep moving forward, and we're really happy about that. But again, we still want to continue to move the bar forward. And so just to show this, when we would see patients prior to 2017, for the most part, this is how we would think about patients. So of course, we'd want to talk about clinical trials first and foremost to try to advance outcomes, but really we would look at intensive induction therapies like 7+3. And for patients who weren't candidates, we talk about lower intensity therapy like hypomethylating agents, low-dose cytarabine. And for some patients, we would talk about supportive care or hospice. And so this figure just kind of shows how complicated things have become. And this is not necessarily a bad thing, but just shows that we really need to be more thoughtful when we are having patients who come in with newly diagnosed AML and talking about the different treatment options that may be available and what that looks like. And so this is really just a graph that depicts for newly diagnosed AML patients and how we try to think about things is based off of the different cytogenetic features, such as certain changes called core binding factor. There also can be patients who've had therapy-related AML or AML with MDS-related changes. And then we also look at different mutations, such as FLT3 or IDH. And then in this final column for all comers is where you'll see venetoclax and HMA therapy or venetoclax with low-dose cytarabine. And these are considered less intensive regimens, but we'll talk about that a little bit more and what that truly means. So now to really talk about the mechanism of action. And so I'm going to start off by talking about really the two drugs that are the backbones for venetoclax. So hypomethylating agents and cytarabine. So for hypomethylating agents, azacitidine and decitabine are the two drugs that are commonly used. And these are cytidine analogs. And they were originally intended and developed as cytotoxic drugs to be given at higher doses. But it was discovered that at low doses of these drugs, they could target increased what we call methylation seen in AML cells. And so when you have increased methylation, that leads to silencing of really important genes that if they were not silenced would tell the cells, the leukemia cells, to either kind of mature, grow into normal cells, or would tell the cells that they're abnormal and signal the cells to die. or also known as apoptosis. And so azacitidine and decitabine inactivate this DNA methyltransferase 1, or DNMT1, which is the enzyme responsible for hypermethylation or overmethylation of the DNA. And so in this way, a low-dose hypomethylating agent therapy is able to induce re-expression of previously silenced genes. And this is how this therapy is felt to work to lead to complete remissions in patients. Now, cytarabine works a little bit differently. It's a pyrimidine analog. And so essentially it's converted into this form within the cell, and it competes with cytidine as a nucleoside to incorporate itself into DNA. And so when that occurs, if it gets incorporated, it really hinders the rotation of the molecule, DNA replication, and again leads to apoptosis of the cell. So to talk about the Venetoclax, so Venetoclax is a BCL2 inhibitor. So the BCL2 family members include BCL2, BCLXL, and MCL1. So these promote cell survival by binding to these proteins Bim and Bax. And these are pro-apoptotic proteins and kind of renders them ineffective. And so Venetoclax, when it comes along, it will prevent this binding from occurring. And so Bim and Bax, these proteins then can signal to the mitochondria that that the cell should undergo apoptosis, and so leads to cell death. And so as I mentioned before, hypomethylating agents were already used as single agents, but in preclinical studies, people looked at the addition of Venetoclax to hypomethylating agents and saw increased apoptosis of cells, and things that were encouraging to look at the combination in AML patients. So this eventually led to this randomized phase 3 study. It's called, we refer to it sometimes as VALIA, but it is the randomized study that led to the full FDA approval. And so this study was performed at multiple sites. It was a double-blind study, so the investigators and patients receiving weren't sure if they were getting the actual Venetoclax versus the placebo. And this was randomized phase 3 trial. And so this was for patients who were newly diagnosed, who were not considered eligible for standard intensive induction chemotherapy. And that could be defined by age 75 years or older, or if there were particular comorbidities like issues with lungs or heart, that it was not felt safe for them to receive cytarabine and anthracycline as a 7+3. So patients, again, they were randomized to either azacitidine or Venetoclax, or azacitidine with a placebo. And azacitidine was given at 75 milligrams per meter squared, and it's given daily either by an injection subcutaneously or by an intravenously, so by IV daily on days 1 through 7. And then Venetoclax started also on day 1, where it would have a ramp up over the first few days, which I'll talk in more detail in another slide, but to the goal of 400 milligrams daily. And then the placebo, of course, was given daily on daily as well, starting on day 1. And the cycles were considered 28-day cycles, which I'll talk about that in more detail. But if patients achieved a response to treatment, then essentially they could continue on with the treatment until progression, or if they became intolerant, if there were toxicities, or if they decided to withdraw consent, as some patients went on to bone marrow stem cell transplant after receiving or achieving a response. So the primary endpoint of what was being looked at was overall survival. So, you know, one of the highest bar really for cancer studies, we want to improve overall survival. Also looked at rates of complete remission, which is where there are less than 5% blasts in the bone marrow and you have full recovery of your platelet count to over 100,000 and your neutrophils to over 1,000. And then also CR plus CRI, and that just essentially means complete remission with that less than 5% blast. But either your platelets or your neutrophils have recovered, but not both. And so there were some other factors they looked at as well, such as quality of life, transfusion independence, and things that I think are very meaningful to patients. So when they looked at, when the study was completed and they did their analysis, they really saw that there was a benefit to adding venetoclax to the azacitidine. The complete remission plus complete remission with incomplete count recovery, you could see it was 66% with the addition of venetoclax versus 28% with the azacitidine and placebo. And other things that were important, that the median time to response, so how quickly did patients get to these responses? It was shorter in the azacitidine and venetoclax arm, where it was about 1.3 months. So about the end of one cycle, many patients had already achieved a response, while with azacitidine and placebo, it was about 2.8 months. And typically when we counsel patients with single agent hypomethylating agent, we expect 3 to 4 months for patients to achieve a response. And then the duration of the response, so for patients who responded, was longer. Here is 17.5 months versus 13.4 months. However, I do want to point out that the range is very different. You can see that it was starting at 13.6 months, and it had not been reached at the time of analysis, meaning there are patients who are ongoing who are still responding after a few years on treatment, while for the azacitidine, it was 5.8 months to 15.5 months. So other improvements, transfusion independence was improved with red blood cells and platelets in the azacitidine and venetoclax arm as well. And then one other thing I'd like to mention is that quality of life, and that's been more recently published, was also found to be improved with azacitidine and venetoclax, and looking at time to what we call decompensation, looking at fatigue, looking at other things that I think are meaningful for patients. How well, it's great to have a response, but if I still can't do the things that I would like to do, if I feel terrible because of the treatment, you know, that's not really the goal of what the treatment should be. It should be responses, but where quality of life is improved. Also to note, they looked at some specific molecular subgroups, and you can see here that for IDH mutated, FLT3, NPM1, TP53, which are all common mutations we see in AML, that the complete remission rates were higher. However, I will point out later that the overall survival for some of these were not different despite having increased complete remission rates. So looking at overall survival for all comers for the patients treated on study, you can see that the patients who were treated with azacitidine and venetoclax with this blue curve had a median overall survival of 14.7 months, while those treated with azacitidine and placebo was shorter at 9.6 months. And this was at a median follow-up time of 20.5 months. And so because the study met its primary endpoint, this led to the full FDA approval of this combination therapy. So I wanted to stop and just take a minute to talk about, you know, discussions really that would be important to have, you know, with your treatment team, your family, when you're trying to make treatment decisions, whether it's moving forward with something like venetoclax and azacitidine, or if it's something different. And because I think it's really important for your treating team to know, to try to get to know you, though I know you're trying to make a quick decision, but I think it really would help in figuring out what would be the best direction to go, especially when now we're getting to an area of multiple options. So things that I want to know from my patients are, what are your treatment goals? What are you trying to achieve? Is it cure? Is it try to get to transplant? Is it more spending quality time with family, being closer to home? Who's your support system? If some of these treatment requires coming back and forth multiple times per week for transfusion support or treatment, do you have the support system in place to help with all of that? I also think it's important to ask questions of how will this impact my work if I'm still working? What about the ability to be around my family or social events if I'm at increased risk of infection, especially now during the time of COVID? What about your ability to travel? If you have particular hobbies that are important to you, gardening is one that patients typically aren't able to do until their neutrophil counts improve. Ability to be around pets. Are there any dietary restrictions? Are you able to exercise? And then to also think about things from a short-term versus long-term plan, because when you initially start treatment, things can be very different until you hopefully get into a remission, as that maybe once you're into that remission, things will be less intensive with appointment times, lab draws, getting transfusion support. And so I think it's important to keep all those things in mind, and again, have a very good discussion with your treating team. So to talk a little bit more about Venetoclax and azacitidine, this is a calendar that we will give to our patients to talk about or to try to better visualize cycle 1 of treatment. And so I'm going to go through this and point out a few things, but as we talked about, the azacitidine is IV infusion. We typically do more IV infusion at our site as opposed to the injection, but it's given over about 10 minutes daily on days 1 through 7. We do give Zofran or ondansetron as a pre-medication for the azacitidine on all of those days. The Venetoclax also, as I mentioned, starts on day 1, but there's a ramp up to this where if you are not on any medications that could interact with Venetoclax, this is going to be the standard dose. And I'm going to go through what it would look like with some of the drugs that could interact on our next slide. But it would be starting at 100 milligrams. These are pills that you take. Then you go up to 200 milligrams on day 2. And then you reach your goal dose of 400 milligrams, which you will take daily through day 28 for the first cycle. And then once you move on to subsequent cycles, you don't have to do this ramp up. You just start at your goal dose. There may be dose adjustments, again, as certain drugs that interact with Venetoclax come on board, but that would be decided by your treating team. So the reason that there is this ramp up of Venetoclax between days 1 through 4 or 1 through 3, depending on the particular ramp up, is that there can be something called tumor lysis syndrome, where the leukemia cells can break down and can cause release of potassium, release of uric acid into the bloodstream. And so high potassium can cause heart arrhythmias, high uric acid can cause kidney damage. And so we want to be sure that we're looking out for that. So typically we'll want to check labs on the first day beforehand, and then about 6 to 8 hours after the Venetoclax dose. And then on days 2, 3, and during your ramp up, again, 6 to 8 hours after the Venetoclax dose, just to make sure there are no signs of the tumor lysis. And then once you're through the ramp up, typically we then move to twice a week scheduling of checking labs, because we know that this combination treatment initially is going to cause cleaning out of the bone marrow. And so your blood counts will get worse before they get better. And so we want to monitor for needs for platelet transfusions, red blood cell transfusions, and then also kind of looking at your neutrophil cells, which are your infection fighting cells, to make sure, do we need to do any adjustments with putting on preventative, antibiotics. I will mention, though we talk about tumor lysis, it is more rare in AML. it is something that can come up on occasion. It is much more common with a different type of leukemia called CLL with using Venetoclax. But because of that, even slight risk, it's very important we don't miss it in the few patients that it could occur. So this slide really, I wanted to show to kind of show dose adjustments that we have to do to the Venetoclax based off of different drug interactions. And so many patients with newly diagnosed AML are neutropenic. And so many centers will put patients on an antifungal prophylaxis to try to prevent fungal pneumonia, other complications that you can see in an immunocompromised setting. And so this first, I guess, column is the normal dose escalation that I showed on the previous slide. But if you're on a moderate, what we call CYP3A inhibitor, this is an enzyme within the liver. So if it's one that impacts that, that's also, Venetoclax is also metabolized that way. You're going to want to do dose adjustments to lower the dosing. For this, it's 50, day 1, 100, then 200 with a goal of 200. And so the same goes for voriconazole. This is considered a strong CYP3A4 inhibitor. And so this is dose reduced even further with a goal of 100 milligrams. And then a specific antifungal, posaconazole, has this ramp up to 70 milligrams. However, I will tell you that most centers or many centers are treating posaconazole similar to voriconazole because some of the forms of the tablets, getting the pills, can make this more difficult for patients to receive and to adjust. And we're not really seeing bigger increases of myelosuppression with doing this dosing similar to voriconazole. But if you read the FDA label, this is what you will see for these drug-drug interactions. And so just to mention, so when the drugs interact, it means that the Venetoclax is going to be at a higher level. And so this is felt to be with having these doses drop down of the Venetoclax. They should be equivalent to the Venetoclax that you would take without these drugs being on board. So there's some other tips I wanted to just bring up for Venetoclax and azacitidine because there can be, these are things that I've learned through patients and experiences that they've had. But one can be that there can be lag time in the turnaround for insurance approval of Venetoclax. And so there can end up being high co-pays, things that you need to apply for grant assistance. And sometimes we need to end up starting treatment with a hypomethylating agent beforehand, and then the Venetoclax is added on when that does get approved and when it can be shipped. The second thing I wanted to mention is that for the first cycle, treatment can be given inpatient or outpatient. But it's really dependent on individual patient factors, the treating institution, but typically after the first cycle, the therapy is then transitioned all to outpatient therapy. And so another thing that can be a little bit difficult to wrap your head around is that we talk about 28-day cycles of treatment. And so that is true for the first cycle, but the second cycle is not necessarily going to start on day 29. It's really going to be dependent on performing a bone marrow biopsy at the end of the first cycle. If we're not seeing leukemia cells in the blood, we want to see if you've already responded because the response time can be so quick after one cycle of treatment. And so if the counts are low, we see no evidence of leukemia in the bone marrow, we're going to delay starting that next cycle of treatment in order to give your bone marrow time to recover. What we don't want to do is give you increased side effects toxicity by just restarting the treatment if it looks like you've had a response. And so to get to where platelets can improve, white blood cell count can improve, and getting into more of that complete remission requirement. If you did still have, and so that can delay, and then as you're going along further into treatment, the treatment in itself, the venetoclax and azacitidine, may need to be adjusted because it can cause myelosuppression or decreased blood count. And so those are things that need continuous adjustment and discussion as we go along. And as I mentioned before, we do think about antimicrobial prophylaxis or antibiotics for patients. That can be treating center patient dependent, but most patients are treated on antiviral prophylaxis, antibacterial, and antifungal if there's concern for prolonged neutropenia, which is the majority of our patients. And so this is what I was referring to just a few minutes ago about dose adjustments for subsequent cycles after achieving a response. So when you have cytopenias or low blood counts, in particular platelets and neutrophil counts are what we're paying attention to. After you achieve a response, we have to allow time for recovery of those counts. And so per the FDA label, if there's more than 7 days from when you would be expecting to start your next cycle of treatment that you have to delay, then you would, for the first occurrence, recommend continuing at the same dosing schedule after it resolves or gets to grade 2 or less. For subsequent occurrence, they would then recommend decreasing the venetoclax by 7 days for each subsequent occurrence. And so some patients are on 21 days of venetoclax or 14 days, or sometimes there are ways we finagle where it's 10 days, but it's really can be very physician or treating center dependent. I will say most physicians will dose reduce in the second cycle to 21 days, though there can be variability among providers. The reason being is it's thought that 28 days really is too strong for ongoing treatment because of that myelosuppression. And there was a study that was published, it was a post hoc analysis that really showed there was no difference in median overall survival in patients who converted to 21-day cycles after their initial cytopenic event versus kind of waiting and following more along the lines of the FDA label. Another thing that could be brought up or mentioned is that if you're having prolonged count recovery from a neutropenia standpoint, you can add on growth factor support to help aid in that neutrophil recovery as well. So now I wanted to just move on and talk about some of the more, I guess, controversial, one of the controversial topics or things that is being studied currently with venetoclax and azacitidine. So as I mentioned, so if you start treatment with venetoclax and azacitidine, unless you are able to go on to stem cell transplant, how we counsel patients is that this is going to be an ongoing indefinite therapy as long as it's working. Also, as long as you want to continue on it, because there's always a choice, and as long as it's safe. We know if we just stop the treatment, or what has been thought is if you stop the treatment, the leukemia is going to come back more quickly. However, this is a swimmer's plot where groups that treated patients on the VALIA study, different centers kind of gathered patients who, for this top group with the green, after 12 months of treatment, for various reasons, decided to stop therapy. And as you can see, that there are a number of patients, so it's small numbers, but patients who had continued complete remission for years. There's some patients who are 5+ years out from treatment and still in remission with no signs of disease. Now, many of those patients, but not all, they check for something called measurable residual disease around month 12. And many of those patients were MRD negative at that time. There are some patients, they did not have that data. And then there's some patients who stopped. There were a few that went on to subsequently relapse, which is depicted by this kind of orange bar at the end. And they compared these outcomes to patients who just continued on indefinite treatment. And so I think one of the next big questions is going to be what particular patient, if they achieve these particular milestones, would be able to stop therapy, at what point in their treatment. And so I think that's exciting to think about. Not everyone needs to think about an indefinite treatment, because that can be daunting. That can really affect quality of life as well. And so I'm excited to see what efforts come forth through further investigation into this. So the next, area of controversy is for patients who have TP53 mutations. So TP53 mutations, we know, are more resistant to intensive induction chemotherapy, hypomethylating agents. For patients who undergo transplant, they are more likely to relapse. And so I think what everyone was very excited about was, with the addition of Venetoclax, would that help improve outcomes for this very high-risk subgroup of patients? And so Dr. Pollier and colleagues looked at patients who had been enrolled in the Valier study and a prior earlier study with this combination therapy, and looked in particular at patients with poor risk and intermediate risk cytogenetics, and then looked at the impact of TP53 mutations. And so what you can see here is that the complete remission rate for TP53 mutated patients with poor risk cytogenetics was still higher than what was seen with azacitidine alone, so 40% versus 16%, but definitely not as good as for patients with poor risk cytogenetics who were TP53 wild type, where the complete remission plus complete remission with incomplete count recovery was 70% versus 22% with the azacitidine alone. The problem is that even though for those TP53 mutated patients, that even if the complete remission rates were higher, the overall survival really was not impacted. And you can see this purple dotted line is for the poor risk cytogenetic patients with TP53 mutations, which those are commonly seen together. The survival probability is very low. When you add it, this blue or greenish dotted line, which is the addition of Venetoclax for the TP53 mutated patients, you can see there really was no difference in overall survival. And so now there's a lot of discussion in regards to, should we add Venetoclax? It's not really improving overall survival, or for patients who were maybe trying to get to transplant, should we do that? But no, we need to move to transplant really quickly. And I think really the goal for this population of patients is to figure out just new therapies, new things to try, and hopefully to improve where we currently are, which is not in a good place for patients with TP53 mutations in our treatment options. The other, I think, area of controversy is for IDH mutated patients. And this is just because in 2022, ivosidenib in combination to the IDH1 inhibitor in combination with azacitidine, study results came out where it was compared to azacitidine and placebo. And so this was not compared to azacitidine and Venetoclax, but this randomized trial tried to see if one was better, and their primary endpoint was event-free survival. And so they did see that event-free survival was improved with the ivosidenib and azacitidine for newly diagnosed IDH1 mutated patients compared to azacitidine with placebo. And you can see complete remission rates were 47% versus 15%. And when they looked at as far as complete remission with incomplete hematologic or platelet recovery that was slightly improved compared to azacitidine. So I think the other thing is for the overall survival for patients who responded, or for overall survival for azacitidine and ivosidenib, it was 24 months versus 7.9 months. And so we know from Back to the Valley A study that the complete remission rates were around 75% with azacitidine and venetoclax, while they were 10% with azacitidine and placebo arm. And then when you looked at the overall survival subgroup analysis, those patients did favor azacitidine and venetoclax. But the problem is now we have two treatments with azacitidine backbones, one with IDH inhibitor and one with venetoclax that are FDA approved and work well. And so the question is, which one do you pick? Is there a sequence that would be better to give the treatment? Are there particular other patient features that may, weigh into making this decision? And so I just put this here is that we currently, myself and Dr. Eisfeld, have a study that is enrolling that's going to be multi-site, looking to answer this question, where patients who are newly diagnosed, who are age 18 and above, who are not candidates for intensive induction, who have either IDH1 or IDH2 mutations, would be randomized 1-to-1 to an IDH inhibitor plus AZA versus ven and azacitidine. And if there's a failure of treatment and it's appropriate, then the patients then would switch over to the treatment they hadn't seen. And so we're trying to get to the bottom of what's the best direction to go for patients who have multiple options. So finally, I wanted to just briefly talk about venetoclax with a different backbone, the low-dose cytarabine. So this is the Valley C study, where it was also a randomized phase 3 trial that performed at multiple centers, double-blind, and it was also for patients who are ineligible for intensive induction due to age or comorbidities, and they were randomized to venetoclax, which had a different dosing. It had a ramp up to 600 milligrams daily given daily on days 1 through 28, and low-dose cytarabine, which is a sub-Q or IV given on days 1 through 10 of a 28-day cycle. And that was randomized with low-dose cytarabine and placebo. And again, similar, they could stay on until progression, intolerance, or withdrawal of treatment with a primary endpoint of overall survival. And so you can see the complete remission rates were about 27% with venetoclax low-dose cytarabine versus 7%. CR, CRI combined 48% versus 13%. Transfusion support was also improved. But when you look at overall survival, and this is an extended overall survival analysis when they had 6 additional months of follow-up, the median overall survival was 8.4 months versus 4.1 months with a low-dose cytarabine. And so though this is also approved for newly diagnosed patients, I think with the data that you shouldn't really compare studies to each other, but I think people are more impressed at the moment with venetoclax, with azacitidine or decitabine as backbones. And so that typically is a frontline choice for the majority of patients if you're going on a venetoclax-based regimen. And then venetoclax, I also want to mention in the relapse refractory setting. So this was first studied as a single agent before it was given in combination in the relapse refractory setting, and the responses were modest. So I think now people have looked at, can we use hypomethylating agents and venetoclax for patients who haven't seen that, such as if they receive 7+3 when they relapse, or if they don't respond to 7+3 or those types of regimens. And this is just a single center study where they talked about their outcomes for patients who have been on venetoclax combinations, so 77 patients. But the responses really have been decent, to where complete remission 35%, complete remission with incomplete hematologic recovery, 18%. So the composite complete remission rate was 53%, and that's not bad. And so I feel like unless there's a trial or something different that's FDA approved, many people will use Venetoclax and HMA therapy in the relapse refractory setting if the patient hasn't had prior exposure to those agents. So future areas of investigations, just to have in the back of your mind, and I'm happy to talk about more, but now there are hypomethylating agents that are given as oral compounds. So people are looking at giving Venetoclax with the hypomethylating agent pills, which I think would be a big game changer in the fact that patients don't have to come to clinic for 7 days in a row. There's more flexibility in that. And so I'm really excited to see if, those are going to be able to move forward and get FDA approved. There are also a lot of talk about triplet therapy, so combining Venetoclax, azacitidine with IDH inhibitors or FLT3 inhibitors. And so there's some early data looking at those, and we'll see how they move forward. Also talking about dose reductions of Venetoclax up front. Do we really need 28 days? Are, patients respond? Could we eliminate Venetoclax later down the road? Could we have treatment holidays in certain patients versus discontinuation? People are also looking at combining Venetoclax with intensive induction therapy and seeing if that improves the bar there as well. And then we're thinking about alternating cycles of treatment, so Venetoclax, HMA for one cycle, and then maybe you do something different than that to try to help with tumor escape mechanisms. And then lastly, Venetoclax is also being looked at as a maintenance therapy after transplant. So in summary, most importantly, I think it's important to have an informative discussion around goals of care and expectations with therapy, and that should occur between patient, their family, support system, and the treatment team before the initiation of any treatment, and really should continue throughout your care to make sure you all are on the same page, and the patient should drive that for what their goals are of their care, and that can change, that can evolve, from starting treatment and moving forward with treatment. So I do think those are really important discussions to continually have. The other thing I wanted to just mention, non-intensive treatment does not mean low intensity treatment. And so Venetoclax in combination with azacitidine does have myelosuppression. There can be toxicities with it. And so it's not something that it's definitely lower intensity than like a 7+3 combination, but there are things to keep in mind that it's not really an easy treatment. Hopefully it gets easier as people respond and can back off of Venetoclax days and have improved blood counts, and that improves the quality of life. And then lastly, the addition of Venetoclax to HMA therapy has improved outcomes for patients, but we still have work to do. And so we always want to continue, like I mentioned, to raise the bar and do better and really get to a place where hopefully we can have more curative therapies available for patients with AML. So with that, I am going to end my talk and just say thank you for your time.
Thank you so much, Dr. Mims. That was an excellent presentation. It's so interesting to hear how far we've come, where we started with Venetoclax and where we are now, and how much potential and opportunity there still is. There's still a lot of questions to answer. Mm-hmm. Let me go ahead and share my screen, and we will start our discussion. We have about 11 minutes or so. I see some questions coming up in the chat already. But for those of you who would like to contribute question or discussion at all, maybe your experience with Venetoclax, feel free to make a comment by typing it in the chat box or by raising your hand if you'd like to speak directly to the group. Let's see here. I see something from Maureen. So Maureen says that she often sees a graph showing the comparison between the combination of venetoclax and Vidasa or azacitidine versus just Vidasa alone. And she's wondering what a graph might look like that shows the difference between this azacitidine venetoclax combination versus just best supportive care.
Oh, sure. So, no, that's a great question. So, I think so. So I guess the question is really what would the bar be? And so when we've looked at that, and so within the Beat AML study, we looked at patients who did, clinical trials, standard of care, and supportive care, best supportive care. And so definitely that moves the bar over. So and there have been studies as well looking at best supportive care versus hypomethylating agents, and the outcomes are worse, meaning that that survival is shorter with doing best supportive care for patients. Though I do think there is benefit in doing best supportive care because if getting transfusion support can make people feel better, live longer, have more quality of time. And so I definitely think that there's still a good role for that for patients.
Great, thank you. Here we go. So a question from Mary here, and this is one of the most interesting things I found going back to your indefinite treatment slide and the question there. Mary's asking if there's any common themes emerging yet in the research on patients who are finding success in stopping treatment. And I guess I'm just curious in a little more expansion of the idea of like, if somebody reaches MRD negativity, is that the point where you might consider stopping treatment and then continually reassess MRD status to decide whether to start and stop? I know that's early thinking, as you said, but I'm curious the thoughts.
Yeah, so I think that's a great question. I think some themes that are emerging is that for some of the IDH mutated patients, that seem to be some of the groups that seem to be more represented in that group. I think also NPM1 mutated patients also were I think the problem right now is that we still don't know, how do we truly define MRD and AML? That's still a little bit controversial. Is it mutations? Is it by flow cytometry? Is it by both of those tests? But I think, if you've had a prolonged response on treatment, I think it's worth a discussion. Though I will say that graph that I presented was with small numbers of patients. And so I do think there will be more data that comes out over time as there are more patients treated with that combination therapy.
Great. Maureen's also asking, what are the side effects of the combination therapy besides low blood counts and platelets, red blood cells, neutrophils?
Oh, sure. So the tumor lysis that I mentioned is one, not common, but one that can come up. But typically the myelosuppression is the biggest thing. I would say I have some patients who can have some nausea, some diarrhea, but it's not as common. I would say fatigue, especially during that second and third week on a cycle. People tend to have their nadir with their kind of energy level that tends to pick back up before starting the next cycle. And so people can have some hair thinning, but people don't lose their hair typically fully with this treatment. So those are kind of the major side effects.
Okay, great. And Pat here, she has a question. It's a bit personal to her. I know it's hard to comment on personal stories and situations, but maybe there's a general answer here. Pat says she's 3 years post-transplant, had 2 successful cycles with azacitidine, and I think she meant venetoclax.
Mm-hmm.
She's 3 years post-transplant, was successfully treated with azaven prior to transplant. She's not on maintenance because she couldn't tolerate gilteritinib. and is wondering if Venetoclax would be a potential option for her for maintenance.
That's a good question. So I do think there are some people, there's more, not as much data, I will say, about that. There are some people who are using either hypomethylating agents alone because there's some data for that. There's also some limited data with hypomethylating agents plus Venetoclax. And so I will say that it can be more difficult to tolerate in the post-transplant setting, you know, just with everything that you've been through from a transplant perspective. But some centers are using that as a maintenance, especially in people they consider higher risk. They will try that because of the if there's concern for really high risk of relapse.
Okay. And she's also asking if there's any long-term effects from this therapy. You mentioned some of the actual side effects, but has there been anything seen, you know, years down the line of issues from this medication?
That's a great question. I think, you know, with the treatment being FDA approved in 2017, you know, I know with the patients on study, it was before, you know, some were on, of course, before that time, but there's not been anything to date as far as kind of long-term side effects or complications with this combination therapy. But I think that's something we'll continue to see as more patients are treated and are on therapy longer.
It's definitely still a lot to learn, that's for sure.
Yeah.
Okay, I think we're caught up on the chat. I don't see anybody's hand raised. Maureen says this was very informative. Thank you, Dr. Mims. Yes, we all agree, I'm sure. I had a question. Maybe I could just ask if, in the meantime, if anything else wants to come in. But early on, you mentioned that Venetoclax is used in combination with HMAs. So we have azacitidine, we have decitabine, and then potentially low dose cytarabine. And I'm curious how that decision is made of what to put Venetoclax in combination with. Is there a specific rationale of who might get one or the other?
Oh, sure. Yeah. So I would say for the majority of patients, if it's just all comers, people are going to pick Venetoclax, hypomethylating agents because of complete remission rate, overall survival. You shouldn't compare, you know, study to study, but those things appear to be much better than what was reported for the low dose cytarabine and Venetoclax patients. I will say for the VALIA study, they did not allow patients who had MDS, who had hypomethylating agent exposure, that then transformed to AML, go on to the study. That was an exclusion criteria. And so there's a lot of questions about what is the best therapy for patients who've had prior hypomethylating agent exposure. And I think some kind of single study analysis looking at that, it doesn't seem like those are great responses, you know, to add Venetoclax to hypomethylating agents, though there can be some. And so I think for those populations who maybe have seen hypomethylating agents prior, you might want to think about low dose cytarabine with Venetoclax as a potential option.
Great, thank you. Nothing else has come through, so maybe we can wrap up with this. You kind of mentioned some future directions and some bullet points there, but I'm curious for you specifically, like what appears to be most exciting in the world of Venetoclax? What's coming in the near future potentially?
Oh, I think there are a lot of there's just so much I think that that people are trying to learn, and so I think some of the exciting things are, can we evolve to all oral combinations? I'm really excited about that because, again, I think from that quality of life perspective, if you can take 2 pills at home, you know, come in for labs, but you're not, you know, spending a week in clinic. I'm excited for that. I'm also excited, really, like we were talking about, are there patients that really are maybe being cured with this, and figuring out what those populations are. You know, if you have a patient who stopped after being in a deep response after a year, and then 4 years later, they have still not relapsed. I think that's really amazing. And I think there's also some exciting data for triplet therapy, in particular with IDH mutated Venetoclax and hypomethylating agents that, may also show really great responses. But, so I think there are all kinds of things that are very exciting. And so I think it's from finishing my fellowship training, which I did in 2012, to kind of where things are now, it's just a whole new world. And I'm excited about that for patients. And I feel like, things are really moving forward more quickly. And so I'm excited that we'll be in an even different place 5 years from now.
Yeah,
different meaning better. Yeah.
Yeah, definitely. Well, hopefully we can have you back, whether that's another virtual event or maybe on our podcast to talk about some of these exciting updates as they become more solidified. So we're just so happy to have you here with us today. We thank you so much for volunteering your time and providing us with this great amount of knowledge. So thank you.
Yeah, my pleasure.
So I'll take a second just to mention our next Adult AML Chapter event, which will take place on December 1st from 2 to 3 p.m. Eastern. We'll be joined by Dr. Derry Vick, who's a psychologist at Hackensack in New Jersey, who will speak to us about stress management strategies. You can visit healthtree.org/AML/community/events in the next week or so to register for this event and others. Once again, thank you to our HealthTree Community for AML event sponsors, Bristol Myers Squibb, Amgen, Genentech, AbbVie, and Jazz Pharmaceuticals. And thank you for helping us build a strong HealthTree community for AML. I appreciate you all for spending your afternoon with us. I hope you have a great rest of your day and really hope to see you again at our next event.